I'm so very pleased that we were able to secure Kevin. Kevin Dayhill is President and CEO of the Nassau-Suffolk Hospital Council and NORMAN, the Northern Metropolitan Hospital Association. These two organizations comprise the Suburban Hospital Alliance. Kevin also serves as Executive Vice President of the Healthcare Association of New York State. He's routinely sought for his expertise on a variety of healthcare issues, such as hospital economics and finance, health services planning, hospitals and community benefit, workforce issues, corporate compliance, quality and performance improvement issues, and managed healthcare practices. In July 2010, he became president and CEO of the Northern Metropolitan Hospital Association, located right here in the Hudson River Valley in Newbury. The co-joining of these two associations allows for more targeted and intense advocacy for the suburban hospitals on Long Island and in the lower and mid Hudson River Valley. Now, Kevin oversees these two metropolitan hospital associations, two of the largest in our state. And with his leadership and hospital policy expertise, presents an even stronger collective voice for all not-for-profit hospitals in these two regions. He imparts his healthcare administrative knowledge to numerous organizations and sits on a variety of healthcare and task forces. In addition, he often serves in an advisory capacity to local, state, and federal elected officials on matters related to healthcare, legislation, and policy development. Currently, he sits on the boards of the New York Organ Donor Network, the Urban League of Long Island, Hudson Valley Pattern for Progress, and the MBA Advisory Board at LIU Hudson. Kevin previously served as President and CEO of United Hospital in Port Chester, New York. And February 21st, 1945, I was born there. You remember that? Huh? I was the one screaming and yelling. Previously, he held a variety of administrative positions that spanned 25 years at Columbia Presbyterian Medical Center in New York City. He holds a Bachelor of Science degree in Healthcare Management from St. Peter's College and a Master's in Business Administration from Fordham University. He's a member of the American College of Healthcare Administrators and the American Association of Association Executives. Now, in addition to this morning's presentation, the Chamber and NORMAN will be presenting a healthcare panel discussion on Wednesday, December 5th, right here at the Poughkeepsie Grand Hotel. So you'll be hearing more about this very shortly. I'm going to ask, before our keynote speaker comes, the people in the front, could you put the balloons down? People in the back can't see, that's why. We are so very lucky to have this keynote speaker, especially right after our national elections. Hopefully he's going to help us try to understand what to expect going forward. Would you please welcome my very good friend, and yours, Kevin Dayhill.
Thank you. Good morning. What a lively group, and a happy group. And I'm going to talk to you about healthcare. Try not to send you away clinically depressed, which is going to be a challenge, but I promised Charlie that I would do that. It's great when your staff writes your bio for you, because they're kissing up to you, right, when they include all that stuff. But I appreciate the very nice introduction by Charlie. And I was asked to talk about the election results and what it means for healthcare policy going forward, both at our federal level and our state level. And pretty clear from my bio that I do represent the hospitals in the lower and mid Hudson Valley and out on Long Island. And I am with the State Hospital Association as well. And I always like to remind audiences that when we talk about hospitals and we use the term healthcare interchangeably, that you need to recall, as I go through my comments this morning, that the hospitals represent a segment of the healthcare world in our society, right? If you go to the dictionary and you look up the word hospital, certainly in Webster's dictionary, it says it is a community-based organization that welcomes the sick and injured. And that's true. In essence, that is true. We also, in this country, deliver babies, as we did with Charlie in 1945. We also deliver babies. That's not a sickness or an illness, thank God. In the far majority of cases, that's just to safeguard a natural event. But in essence, our hospitals are there to welcome the sick and injured. And in the last 3 weeks, I'm sure you've seen all the news accounts of the results of the storm, and there's no better evidence of that going on. But that's only a piece of the healthcare sector. In fact, if you looked at the whole healthcare industry in this country, the hospitals are just a piece of it. And in fact, when you think about them welcoming the sick and injured, you almost could start to say, well, maybe that's a failure of our healthcare system, because people do become sick and injured. Now, we can't avoid every illness, we can't avoid every injury, but certainly we will contribute to illness and sickness when we eat too much, when we drink too much, when we drive 100 miles an hour, or whatever. Our behaviors drive very often the healthcare system here. So when we're talking about this, and on December 5th, when we get into a lot more detail at the event here, I would ask you to keep that in mind, that when we look at hospitals, we're looking at just a piece of the puzzle. Having said that, when somebody does become sick or injured and they have to be treated at a hospital, the costs for that are very expensive and very high. So our tendency, and it's very natural, and I'm sure in your businesses you do this all the time, when your margins start to shrink, where's the first place you look? You look at your costs, and you look at whether or not you can make your business more efficient. But you probably also know from your business life that you can only do that so much. And in fact, if you just stay focused on your costs, while not paying attention to what's contributing to your woes, your margins shrinking, you could miss the boat, and you could be driving your business into the ground. And so that's where we're going with healthcare, it seems to me, in this country. The election results in the past few weeks at the federal level, after hundreds of millions of dollars got spent and months of campaigning, nothing changed, right? In essence, President wins re-election, the Democrats maintain control of the Senate, and the Republicans the House of Representatives. So we've had some give and take in that regard, even in this region. But in essence, nothing has changed. Leadership is going to be the same going forward, and there's a lot of work that has to get done in the next several months, and I'll talk about that in a couple of minutes. Why should you, as the Dutchess Chamber of Commerce, concern yourselves with the hospitals in Dutchess County? And let me give you a couple of facts. Your hospitals here in Dutchess County contribute, first of all, they represent 5,300 jobs in the community, about $32 million in state and local taxes that get paid. And there's a lot of indirect spending that's caused to happen because of your hospitals. So I tell you that because I want you to consider what the hospitals are encountering, what they're going through with a lot of the policies that have been put in place and that are going to be put in place, and come to understand what effect that could have on your hospitals. Because I'm going to make a request as I get ready to conclude my remarks in a few minutes, that we work much more closely together as a chamber and as a hospital association. So the election results at the federal level mean that the Affordable Care Act, which was passed 2 years ago, will now go ahead, full steam ahead. And in fact, the administration is already promulgating rules and regulations, even in the last 48 hours, that they held up pending the results of the election. So these things are going to go forward. You may be aware that a major part of the Supreme Court challenge of the Affordable Care Act last year had to do with states' rights and whether or not the federal government could dictate to the state that they had to put in place a health insurance exchange, that they had to set their Medicaid rates at a certain level, and the Supreme Court responded to that in a very courageous way by saying the federal government can tell the states to do it, but the states don't have to do it if they don't want to. So we are in a situation, when you look at this Affordable Care Act nationally, we're in a situation where some states are choosing not to implement the law, while other states are going full steam ahead. New York is one of those states that's proceeding full steam ahead. The governor, at the close of last year's legislative session, when he could not get legislation enacting an insurance exchange, he issued an executive order. And that executive order calls for the formation of an insurance exchange, which will comply with the federal requirements, meaning that it'll be operational January of 2014, not that long from now. It also means that the state then was able to draw down a lot of money from the federal government to set up this insurance exchange. So they've hired actuaries and consultants and so on. Now, you have a stake in this, and certainly the hospitals that I represent have a stake in this. Your stake in this is that to the extent you provide employer-based healthcare insurance, you now are under a mandate that you either continue to provide that if you have a certain number of employees, right? Or you encounter a penalty per employee for not providing it. But if you choose not to provide it, your employees then could shop for health insurance themselves through the exchange. And the government, to a certain extent, will subsidize them from those monies that you pay in as penalties. A lot of debate. I'm sure you're all getting a lot of advice from brokers and whatnot about how this might work. But let me characterize it from the hospital's point of view. The hospitals get paid by three different sources, quite frankly. Medicare at the federal level, Medicaid, which is a shared expense between the federal government and the state government, and then the commercial insurers, very often on behalf of you as employers and your colleagues, in our case, around the state. And now we're in a situation where the government, in setting up this insurance exchange in New York, is going to try to create one place where all of those things, Medicaid, Child Health Plus, Family Health Plus, and commercial insurance, will be bought and sold under some level of government supervision. Now, I'm very well aware, when I first met Charlie and the senior staff here at the Chamber, I'm very well aware that this Chamber in particular has a history of looking very critically at overregulation. And I would suggest to you that together we're going to need to be examining how this exchange gets set up and what effect it's going to have on you as employers and as citizens, and on the hospitals that I represent. Because our fear is, quite frankly, that whereas in the past, commercial insurance, separated from Medicare and Medicaid, commercial insurance was a private market activity between the hospitals. Hospitals could sit down and negotiate with the insurers over rates, right? Hospitals don't enjoy that luxury with the federal government, the state government, as you might expect. Now, if you're going to take the commercial insurers and put them into some government-supervised exchange where their rates and the requirements that are going to be put on them cause them to become over-regulated, we fear, the ability to negotiate fair and equitable rates will decline. And that's going to be a major issue. So I would say to you that if you're feeling frustrated about the formation of these things, we are as well. But we think that there's an opportunity. The governor at least put in place several regional advisory committees that seek to get input from local communities as to how these exchanges should be set up. I'm fortunate enough to have been nominated to two of them, one on Long Island and one in the lower Hudson Valley and New York City. So there's an opportunity to weigh in with opinions, and it's a public process. So even if you're not on the committee, you can weigh in. So we're going to be working very closely with you to share our concerns, hear yours, and see if not, there isn't some synergy we can develop between our two organizations, and perhaps even, in many cases, speak with one voice. The Affordable Care Act is 2,674 pages. In there, the devil's always in the details, right? So in there, beyond the notion, if you talk to anyone who had a hand in passing that law, they will say, we don't know what everybody's frustrated and concerned about. It's a wonderful thing. We seek to insure all these people that were not previously insured. And that's true. There is an effort to cover those that are uninsured. And we in the hospitals have been lamenting the fact that we have so many people who are uninsured, citizens of this country who are uninsured. So we can't gripe about that. But the rest of the 2,674 pages has a lot of other detail in it. And a lot of that detail has to do with changes that are intended to occur over the course of the next couple of years that will result in drastic changes, in my opinion, to the way we deliver care. And when I say we, it goes beyond the hospitals to the physicians and other provider agencies as well. And I don't think, and I'm pretty sure that I'm correct in this, I don't think that the general public understands that the law also contained these things, this activity. So what am I talking about? Well, what I'm talking about is that, when you think about Medicare and Medicaid, you have to come to appreciate that these programs were promises put forth by the federal and state governments. Promises that if you're an American citizen and you reach the ripe old age of 65 and you've been contributing a portion of your payroll expense through the years to the program, you are going to get a red, white, and blue card, and you're going to be on Medicare, and you're going to have your health insurance throughout your retirement years, right? Enacted in 1965 under President Johnson, it was a promise the government made to us all. In 1965, part of the deal was we were supposed to die by the time we were 72. We have not kept up our end of the bargain. And consequently, what you will hear the policymakers now talk about is that we can't sustain the costs of this program. They won't say we can't keep the promise we made. They'll say we can't sustain the cost. So rather than say we've got to change the structure, we've got to change the eligibility age, we've got to change, rather than do any of that, to this point, what the choice has been to reduce reimbursements to providers, or now the discussion is even around, let's change the business model. Let's stop paying for volume. Let's stop paying for episodes of care, and let's start paying for outcomes. And let's see if you, the providers, can get people healthier. You manage their care, you take the risk, and if you are successful and they get healthier and they have better outcomes, you'll make some money. If they don't, and they wind up getting sick and complicated and so on, that's on you. In essence, it's basically the government saying, we're not going to just pay on a routine basis episodically. We are going to have you find a way to better manage the care of these folks. Now, problem with that, there's a couple problems with that. First problem is, we're not telling the public about this. In fact, in some of the demonstration projects that have been set up under Medicare, you're not allowed to tell the beneficiary that they're in some sort of a new vehicle and that the provider has some risk, financial risk for your care. Now, going back to when the promise was made and people started getting on Medicare, what was the reaction of the beneficiaries? Well, a lot of people, right, took their Medicare card, moved to Florida, right? And in Florida, they get up in the morning, they go play golf, they have lunch, and then they go see the urologist. And Tuesday, they play golf, and they go see the dermatologist, right? And that's because we've had a system that has encouraged episodic care with the mindset of the beneficiary being, well, I got this card. Government made this promise, I can go and do whatever I want to do and see whoever I want to see. And standing by are the urologists and the dermatologists, and they see you, and they welcome you in. So the government's basically saying, and they're right, that if we can find a way to better manage the care up front, then we'll bring down the cost curve, we'll bring down the expense. So that's correct, that is correct. It goes to what I said earlier, and that is that if we could create a healthier community, if we put incentives in place, then it only stands to reason that the costs will come down, that the hospitals will be welcoming less sick and injured because there will be less sick and injured. But the only way that's going to happen is if you provide the incentives to the public as well, through employer-based insurance, through wellness programs. The office that I have, I'm fortunate enough to have two offices now. I have an office in Newburgh and an office in Hapog. The office we have in Hapog is in an office complex, very large building. And when I go to that office and I walk in the front door of that building, there's at least 15 or 18 people standing in front of that building smoking. And I'm talking people in their 20s today who are contributing to the costs of the future. There's not a doubt in my mind about that. So we have to find a way, and we'll talk more about this December 5th when I'm back to engage in a panel here. We got to find a way to bring the healthcare provider community together with the business community, the employers, to the extent you want to continue to provide health care for your employees or create a healthier environment. And we got to find a way to shift those incentives to those that work for you, their family members, and try to find a way to affect the cost curve that way. Otherwise, this is not going to work. In the meantime, as part of the national scene, the federal government now, as I said, has a lot of work to do in the next couple of months. And the lame duck session of Congress will reconvene next week. And between now and the end of the year, they have to deal with certain issues. And you know, you see them, we are fiscal cliff to death. You keep hearing it all the time on the news now. But it has serious implications for the hospitals that I represent. And I would say to you, it could have serious implications for you too in this community. We would like to come back next year, Charlie, and say our economy is a lot better and that we've made certain progress. That will only happen if we find a way to come up with a political solution to the problems that this country has. And unfortunately, they've set themselves a deadline of the end of this year that they've got to do that. And so the implications that exist for us and for the hospitals are that if they do not negotiate a deal that redirects what are cuts that are already written into law, then all Medicare providers throughout the country will see a 2% reduction in their reimbursement at the end of the year. Here in Dutchess County, that'll mean $45 million in cuts to the hospitals. So that would be taken right out of those numbers I provided you earlier. So, however, if they do reach a deal, what gets contained in that deal is also going to have implications for us in the hospital world and for our physicians, quite frankly, who are facing a very large cut. So my message to you is to remember what I said earlier, and that is that hospitals and, quite frankly, physicians are just a piece of the healthcare sector. They are not the entire healthcare sector. In fact, there's a lot of money being made in the entire healthcare sector. It's not being made in the hospitals and with the physicians. We have a stake in this game, as do you. And even if you, because of your size or your strategies, you do not provide employer-based insurance, you still have a stake in this as a citizen and as a leader in your community. And we want to work with you. We want to find a way to partner with the business community and see if if, whether or not we can share incentives to create a healthier community along the way. It's in our interest, and it's in your interest, quite frankly. We wish you the best for a blessed Thanksgiving, and I really appreciate the invitation to be with you here this morning. Thank you.
We have time for just a few questions. If there's anyone in the audience